We're going to talk very briefly about, we've discussed the metabolic and the medical issues related to it, the mental, the physiological, the pathological, the mental health. And now we're going to talk a little bit about the cost of obesity to society. And again, these are my disclosures. B2M Medical, by the way, in case this is a medical device company that I'm just consulting on, and it has nothing to do with these talks today. So we briefly touched on the burden of obesity, just again to remind you of these stark numbers. Worldwide, 2.2 billion people are overweight and 1.5 billion suffer from obesity. It's a major contributor to the global burden of chronic diseases, as we've mentioned, disability, healthcare costs, and increasingly being identified as a risk factor for cancer. Almost 12% in men and 13% in women. Cancers are attributable or associated with obesity. And this results ultimately in premature mortality and overall decrease in quality of life. And as I mentioned, we have to keep our eyes open because our future generations are being affected at rising rates. The costs associated with obesity, they're hard to accurately measure, of course, but they're estimated to cost as high as $2 trillion around the globe. And this represents almost 3% of the world's GDP. According to WHO, overweight and obesity now kill more people than being underweight. It's amazing how that formula has reversed itself. And the prevalence of obesity among children and adolescents rose from 4% in 1975 to over 18% just a few years ago. And as I mentioned, our pediatric colleagues are alarmed by this, and they're sounding alarm bells across the world. So with regards to the United States, the cost of a high BMI is, with regards to the world, it's $990 billion per year. And among countries that are considered to be in the developed region of the world, the combined direct and indirect costs is 3.3% of GDP. Which accounts for 8.4% of total healthcare spending. And this includes costs to specific chronic diseases and includes also lost productivity from work and absenteeism, cost to patients and families, and cost to insurers and other payers. And this chart depicts the cost of obesity in different countries, and you can see it's high in countries like China and Korea and other countries as well, both the total cost, indirect, and direct costs. With regards to the United States, over here, we are spending almost $150 billion per year on obesity. The costs are predicted to reach $210 billion by 2030. As I said, 50% of our population are expected to be obese. And this results in 9,000 to 17,000 higher costs, healthcare costs in obese compared to normal weight people. The indirect costs, which are not factored in all this, is the higher absenteeism, twice as many workers' compensation claims, higher life insurance premiums, etc., etc. Less than 30% of employers also choose to offer coverage for two most effective treatments for obesity, and that being surgery and anti-obesity medications. And this all adds up in long-term concept to the cost of obesity because it's not being curtailed right now for cost-saving measures. The ASMBS, which is the Society for Bariatric and Metabolic Surgeons, they conducted a survey a few years ago called Obesity in America. And this survey was launched to the lay population to ask them about their opinions about obesity. And the results were quite sobering. Only about half of Americans considered themselves to be overweight, which is significantly less than the numbers reported by the CDC. Most of those who met BMI criteria for obesity considered themselves to be overweight, but not obese. 89%. And 4 in 10 Americans who met the BMI criteria for obesity have not talked to the healthcare provider about their weight. In other words, there's an overall pervasive sense, a state of denial in the country about the incidence and prevalence of obesity in this country. And that is, of course, very concerning because the longer this takes place, the less action is taken. So in summary, global obesity is rising at a fast pace. The metabolic syndrome that I mentioned is associated with several life-threatening chronic diseases. It is a costly disease, one of the most costly that we have. Both direct and indirect costs are involved in this. And sadly, the cost of obesity is predicted to keep rising unrelentlessly for the foreseeable future. Thank you very much. And Dr. Xu is going to talk to us about bias and discrimination. She is the assistant professor of general internal medicine here at Baylor College of Medicine. Thank you so much.
Hi, good morning, everybody. What an excellent series of talks we've already had. A lot of interesting statistics that we've learned this morning, and I hope to kind of contextualize this for both the provider as well as the patient. So I have no disclosures to discuss this morning, and I hope that by the end of this talk, we'll be able to do several things together. First of all, to be able to recognize the scope of metabolic syndrome, as we already well know this morning, define the bias and discrimination in metabolic syndrome, recognize the impact and the impact of bias and discrimination on health outcomes of patients living with metabolic syndrome, and also to discuss methods for improvement when we are designing spaces for patient care, as well as how we can better communicate with our patients, which is something that I still strive and struggle with every day, and I think is a part of our continuing practice and continuing medical education. So as we well know, metabolic syndrome is a worldwide problem. It's interesting to see the change in statistics between this PowerPoint presentation and some of the other ones you've already seen this morning. So as of 2015, the population of the United States, which has significantly grown since Dr. Matar's statistics from earlier this morning. In 2015, it was 321 million. And at that same point in time, there were over 600 million adults worldwide who had defined obesity, so twice the United States population. And then in the span of just 4 years, that number has gone up, as per Dr. Matar's presentation, to 1.2 billion. So a huge jump, an exponential leap over time in a very short amount of time. As we also know, metabolic syndrome, as we discussed, is a growing worldwide problem. And so this is a very busy graph. I don't want you to take everything away from this. The most important parts to me are basically that and you see that all the trends are upticking for everyone. So this divides patients amongst male, female, global population, which is the one in gold that I want you to pay attention to, as well as by socioeconomic status, or SDI is another way that they refer to it, but basically socioeconomic status. And so the contextualization of this graph is from 1980 to 2015. The 2015 obesity collaborators looked at over 70 million people worldwide. And at that point in time, they found that obesity was a growing, rampant problem in nations across the world. And it is projected, kind of morosely, that up to 80% of people in developed nations worldwide will be living with obesity by 2030. So we said 50% in the United States projected in 2030, but 80% worldwide potentially. And so Houston, as such, is a microcosm of the world. These are statistics from the 2020 census for Houston. We have people from everywhere. We're a huge port city. We have people from all walks of life, both foreign and domestic born. And thus, as such, we see patients and we have problems that mirror the problems of the world. This was also a statistic from 2010, so an even bigger jump. So Dr. Matar quoted the statistic of 40%. In 2010, the statistic was 27% of patients with a BMI of greater than 30. So again, a huge jump over the course of time that you see. So something that, I'm going to touch on and want to discuss, but also lay the foundation for, is bias and discrimination, right? And so when we're talking about bias and discrimination as it relates to obesity, two terms that I want us to be very clear on are going to be weight stigma versus weight bias. And weight stigma is more something that is internalized, going on in a person's mind. And so labeling an individual with a certain personality or behavioral characteristic purely based on their body composition and the way that they appear or that they seem. And this is something that goes on in the person, the viewer's mind. Weight bias is something that is an action that occurs or happens thereafter, and they are not the same. And so individuals receive negative or unreasonable judgments about their person based on their body weight. And this can appear in a variety of ways in our medical setting. And so consider the size limits of medical equipment, such as gowns, imaging equipment limits, blood pressure cuffs, scale limits, office furniture, and just the language used during patient encounters. There's also several types of bias that apply kind of uniformly across the board that Dr. Brown knows far better than I do, even so. And so they will be things like implicit bias, so subconscious associations of obesity with negative traits. There's been a long-standing Harvard study where you can take a survey online and you can see basically, do you personally have bias against patients with obesity or people who living with obesity? There's also explicit bias, and these are things that are done with intention, with action based on the person that's doing it. And so these are conscious physical, verbal, or nonverbal actions and thoughts that are intentional and directed at a person. And all of these in summation go to affect our patients even more living with obesity because weight bias can be internalized. And so this becomes a self-directed form of stigmatization and form of self-hate. And everybody has this to some degree, not necessarily about weight, but about a variety of characteristics that you are living with. But when we see our patients with obesity, it is specifically weight bias internalization that we must also be cognizant of as providers and try to fight against and help them correct and rectify for themselves as well. And so weight bias and stigma, not that I am saying this, but is it a socially acceptable form of discrimination? In my mind, absolutely not, but these are the assumptions that are associated with obesity in the world that we live in our society and in our culture and pop culture. You see this occur everywhere. There are thought to have the associations of a lack of willpower, a lack of self-control, and that is why that they are presenting at the weight or that the shape that they are. Laziness, incompetence, that they are unattractive, or that they are not motivated to improve their own health. None of these things, I think, can be taken as being uniformly true across the board for anyone, but these are the associations and the stigma that are associated with the patients that we see with weight. And so weight-based discrimination does indeed cause harm. Adults experiencing weight-based discrimination, especially those who have self-internalized stigmatization, have a 60% increased risk of death. And Dr. Brown kind of alluded to this before, but long-term cardiometabolic risk is related to a 207% estimated increased risk of high levels of allostatic load. So excessive wear and tear stress is causing excessive stress in the patient's body and their life, related to, as those axes Dr. Brown referred to, like the HPA axis. And so this leads to excessive activation, oxidative stress, inflammation into the patient's body, and has systemic manifestations as so many other chronic conditions that we see also do. This also leads to increased physiologic arousal, which when combined with an emotional response, as we've learned about earlier this morning, can lead directly to increased calorie consumption and binge eating, all of which is a vicious cycle. So something that they were, potentially born with or predisposed to genetically, leading to also a vicious cycle of, decisions that are not easy for them to resist. Also, other ways that weight-based discrimination causes harm. It causes a lot of harm in our female population. So up to 55% of women living with obesity report delaying or canceling an appointment if they have anticipated needs of being weighed during their consultation. And so this is 1 in 2. 1 out of 2 women in your life may be saying, I would rather not. And so avoidance of breast or pelvic exams leads to delayed care because we, cannot screen as well for mammography, for breast cancer, for a variety of things due to self-shame involved with disrobing and, just being present for the exam. And so main things, I guess, otherwise to talk about, given those kind of morose figures, are going to be solutions and ways that we can improve our ability to communicate with our patients and ability for care for our patients. So some solutions to consider. So reducing obesity bias in the waiting room. So when your patient comes to the clinic to see you, they don't see me first, right? They have a variety of things to go through before they actually even get to the exam room to see me. And so the first thing that they encounter is walking through the door and seeing the waiting room. And so making it an inclusive space. So seating without armrests, wider chairs to accommodate all sizes so that it's not defined or predetermined for a specific size or person. Adequate spacing between chairs so that the entire area is easy for them to commute and traverse through. Avoiding publications that contain offensive or discriminating images. This is systemic and widely rampant throughout our population, where, like the thin bias, right? Like every publication has a thin, skinny, pretty person on it. And so we don't want that kind of material, because that is not the culture that we want to perpetuate for our patients. That is not how we lead to better self-care. And also training all staff in compassionate language. And so the provider is not the first person that the patient talks to. The first person that they come in and probably talk to is your receptionist, or anybody in the front office. And so making sure that all of your office staff are trained in compassionate language is critical. And then how, once they get to the exam room, do we reduce bias? And so that'll be things like I kind of alluded to earlier: properly sizing gowns, study exam tables with stools or step handles so that mobility is easier. And this applies to a wide variety of patients, not just patients living with obesity. Measuring tapes that are inclusive in size, and so not having a specific smaller limit on them. A lot of times you might go to clinics and they have paper tapes, and those paper tapes are very short. They don't work for a variety of reasons for a variety of patients. Making sure you have legitimate measuring tapes in your clinics. Appropriate vaginal speculum sizes. These, are necessary for important female care, and we need different sizes for different people, like all things. Blood pressure cuffs that come in appropriate sizes so that their measurements are accurate. High capacity weight scales in private locations, and not calling out weight measurements kind of auditorily so that everybody can hear. Bathrooms equipped with handrails that can accommodate all sizes, because, I've had to use the bathroom going to the doctor's office. I'm sure other people have too. And laboratory draw chairs that can accommodate all sizes so that every step of the way they feel that they are being cared for and that they have the appropriate access to the care that they need. And finally, another component that I am still trying to hone and sharpen in my own clinical practice is people first language whenever we are speaking. And so I don't think that this is a one-size-fits-all approach, because every person comes from a different walk of life. And so I think it's very important to be transparent with your patient and establish that rapport early on. And so it's okay to just say, what words would you like me to use when we talk about weight? How do you feel about your weight? Can we talk about your weight today? And when specifically talking about like an unhealthy weight, sometimes it's nicer if you don't refer to it as your weight, but just the weight, like the weight that we see in front of us today. And then would you even be willing to have a discussion about your weight? Because not everybody feels the same way about their weight, and so it's important to contextualize that and individualize that for the patient. And this is just a list of terms you're more than capable of reading yourself. There's some discouraged terms and some encouraged terms. The main point I would like to kind of enlist out of all these terms is that it is very important for us as medical providers to be specific with our language, and I don't want us to think that people first language means less specificity or less detail. But also, we talk about whenever we're going through training that it's important to use language that the patient understands, because the patient has not gone through all the training that we have gone through. And so instead of calling it morbid obesity or obese, we could just refer to it as weight, because that's all that matters to the patient, or unhealthy weight, because we're trying to get them to a healthier weight. And then frequently in our culture, diet and exercise comes with a lot of negative connotations. And so while that word in and of itself not necessarily is a bad word, there are better words that are more specific. So eating habits and nutrition, or physical activity, because those are the specific things that we are referring to, as opposed to all the baggage that comes along with other words that we're using. And also something to consider is people first language when we are documenting. And so consider saying a 43-year-old female patient with obesity as opposed to a 43-year-old obese patient. Because, it is not that obesity is an immutable fact or characteristic of that patient. That is a condition that they are living with, much like all the other conditions that we treat. And so we say with a past medical history of X, Y, and Z. We do not say, this type of person. So some final take-home points are just that metabolic syndrome is prevalent and a growing public health issue. Bias and discrimination in metabolic syndrome is insidious, prevalent, and very harmful for our patients and, for ourselves, for everyone involved in the healthcare system. And introspection in your clinical spaces and language can definitively improve patient interactions by improving the trust and rapport between the provider and the patient. These are my references. Thank you very much.
Good morning, everybody. Again, I'm Olubunmi Oladejoye with the General Internal Medicine Department, and it's my pleasure to be here this morning as well. Just to go ahead, I have no disclosures this morning. Within the next 15 minutes, we will be able to highlight the importance of having a conversation on weight management, to review the challenges and barriers to discussing weight management with our patients, and to discuss how to bring up the topic with the patients. So first, why is it important that we have a conversation on weight management with our patients? We cannot overemphasize that the prevalence of obesity continues to increase, both in the United States and in the world in general. As mentioned earlier, about 41.9% of adults are currently living with obesity in the United States. And if we look at the map that Dr. Mata showed us earlier, more than 30 states in the United States have counties with obesity prevalence that is greater than 40%. And it also accounts for approximately over $100 billion in the annual health costs. And it's also been shown that patients living with obesity, Sorry for the distraction. All right. It's also been shown that patients living with obesity tend to have about over $1,000 in excess of what other patients with non-obesity spend on their annual health costs. Still looking at the importance of having a conversation on obesity, it's important to note that there's higher prevalence of obesity amongst certain racial and ethnic groups. We have made mention to that earlier on. It's been shown that the non-Hispanic Black population have the highest prevalence of obesity, totaling to almost about 50% of their own population. The Hispanic populations are next to this with 45.6%. Studies have also shown that patients who struggle or who have some socioeconomic disadvantage also tend to have a higher prevalence of obesity. It's been shown that those who have at least a college degree do generally, on the average, have lower prevalence of obesity. Again, still thinking about it, why do we really want to talk about this condition? Other than the fact that it's becoming more prevalent, it's a complex condition, and it results from both genetic inheritance and environmental factors. It's been shown that people who have family members who have, who are on the higher or who have increased BMI are more likely to develop increased BMI themselves. It is a chronic condition. And like Dr. Shu mentioned earlier, it should be seen like other existing medical conditions. Just like hypertension, we have no issues with broaching that topic with our patients. We should see obesity in that light as well. We have also talked about it extensively today, and I think we will still hear more about this, that obesity itself increases the risk of many preventable diseases, including cardiovascular disease, type 2 diabetes, hyperlipidemia, and cancer is also not excluded from this. In addition to the medical conditions that are associated with obesity, we also know that persons with obesity may suffer from stigma and diminished quality of life. Sometimes we as physicians are not excluded from the population of people who contribute to the stigma of obesity in our patients, so it would be great to be mindful of this. The good news is there is management for management for obesity now. And it's been shown that with just modest weight reduction, this can very much improve or prevent many of the health conditions. For instance, just a 3% weight reduction we can see can help to improve glycemic control, can help to improve triglyceride numbers or prevent these diseases altogether. And if we're able to achieve even up to weight reduction of about 15%, then there's There's proven benefit in the reduction in cardiovascular events, mortality, and even remission of type 2 diabetes, and be able to get this patient off of their medications for diabetes. Just like we have prescription medications now, there are also many options when it comes to surgical and endoscopic procedures. So many reasons why we should talk about obesity with our patients. Also important is that some of the guidelines that we follow, including that from USPSTF, they have recommended that we actually screen all adult patients who present to our clinics. And we as clinicians should offer or refer patients with BMI that is greater than 30 or equals to 30 to intensive multi-component behavioral interventions. Unfortunately, despite all of this importance of having conversations about weight management with our patient, despite the USPSTF recommendation, we still find that obesity counseling rates remain low among healthcare professionals. And why do we have that? There are many challenges and barriers to discussing weight management. First is time constraints in a very busy practice, particularly for those of us who are in primary care practices where our patients were the first point of call for many of their medical conditions. At times we have these patients coming in with a mind to discuss 5 other problems, weight not included in this. So within that limited time, many of us tend to want to just address their acute symptoms and keep weight management discussion until later. Unfortunately, sometimes the later never comes. It might be important to make use of our annual preventative visits to discuss weight management. And we find out that not many patients also schedule that as well. Sometimes they just come when they have acute issues or they're following up on chronic conditions. So one of the ways to overcome this barrier is to encourage our patients to schedule appointments for their annual preventative visits. Again, lack of effective treatment options were part of the reasons, but I'm happy to say that we're gradually moving away from lack of effective treatment. Previously, other than talking about lifestyle, there were really no medications or a lot of options for surgery or even endoscopic procedures. So that's one challenge that I would say we're starting to overcome. Again, is on the primary care end of we worry about our reimbursement as well. Inadequate reimbursement might be reasons why some practitioners want to avoid talking about it and tend to focus on things that give them more reimbursement. But the good news is that now those are also being reimbursed, and sometimes you can actually see patients monthly, and insurance will still cover that. One of the other challenges to discussing weight management is low confidence or insufficient training in weight management counseling. We find that in many medical schools, there's very minimal training on how to have conversations on weight management, or even on the treatment, medical treatment, pharmacologic treatment, or surgical treatment of weight management. We find that sometimes we have residents who are just learning some of these medications newly when they come on their rotation. So increasing the awareness amongst our residents and medical students would definitely help to prepare, the future leaders in managing or feeling more comfortable with approaching this topic. Again, it cannot be, overemphasized that the issue of weight still remains a sensitive matter, and some people fear that, they may insult the patient by talking about it. Also, we know that many of our patients are of diverse backgrounds, and for some of them, the weight they may not feel that's an issue. We may be afraid of bringing that up because we're afraid to insult the patients. Again, attitudes or biases that are particular to obesity may tend to limit our discussion on patient weight management. And that includes for us as physicians as well. What biases do we have about weight management? Do we have in our mind that when we see people with increased BMI, sometimes we first think they're not exercising, they're not eating right. Having that on our minds may actually prevent us from effectively having these conversations with our patients. So these are some of the things we can overcome, and especially the more we do it, the better we get at this practice. All right, who will benefit from having conversations about weight? The criteria includes patients with BMI of 30 or above, Those with 25 to 35 with 2 or more weight-related health problems, those with waist circumference that is greater than 35 inches for females or 40 inches for males, and they have 2 or more weight-related health problems. And if we have anyone with BMI 25 to 30 who have one or no other risk factors, they may also still benefit from discussion about weight gain prevention. If we have patients who have brought it up themselves, whether they moved from a BMI of 24.9 and went up to 25.2, and they're concerned about that, we should feel free to also have that conversation with these patients. Now, coming to the big topic, broaching the topic of obesity. Clearly, there's no established method for talking to patients about their weight. It still remains a very sensitive topic, and for that reason, initiating that talk is usually an interactive process where there is information sharing between the patient and the physician. And our words definitely matter in having these conversations with our patients. We want to be careful, like Dr. Shu mentioned earlier. The language that we want to use should be first person. We should avoid terminologies that tend to increase bias or bring stigma or shame to the patient. So the language that the physician uses is very, very important. And what we do at this time determines how the patient will respond, to the issue of weight management. So in broaching the topic of obesity, first I would say in terms of language as well, we want to be open-ended. Ask open-ended questions. We should avoid the yes or no questions as much as possible. Why? This helps the patient to express themselves and actually speak out, everything that they think might have been limiting them or things that they have in fact been doing well to work on this. We should be very empathetic when we talk to our patients. And most importantly, we should be non-judgmental. We should not make them feel as though they have brought this upon themselves, but instead work with them to see what we can do better. We should be very alert when we're talking about this with our patient. We should be sensitive to cultural differences as well, especially for those that some patients may have with weight. There are some people that feel more comfortable with their current weight and would think that when they lose weight, others are going to perceive them as though they just recently had an illness. So we have to be sensitive to some of those. Same thing for variety of food options. We should not necessarily limit them to what we think are the right food options, but going over what they really like and helping them see which ones are healthy or what portions sizes they could do. Motivational interview technique is also very important in this. With the motivational interview, the main aim is to balance good listening with providing advice. We should remember that even though we are the experts in the knowledge, patients are the experts about their bodies. They know how they feel in their bodies, they know how their bodies react to things, and we should keep that in mind. So there is the 5 A's concept that originated with the US Department of Human Health Services. Initially, it was used for smoking cessation, where the 5 A's actually stand for ask, assess, assist, and it stands for assess, advise, agree, and assist. It's now being used and modified to weight counseling. The ask is actually asking for patient's permission to discuss the weight. It's okay to say, would you be open to discussing your weight today? Would it be okay if we talk about your weight today? But that also being said, if the patient did bring up this conversation themselves, we could potentially skip this stage. But if it's the physician initiating it, it is just very nice and appropriate to ask for their permission to discuss this. As part of asking, we want to assess their readiness. We want to assess their readiness for change. Some of the questions we can ask is, what is your actual motivation for weight loss? In having that conversation, we should make sure we're actively listening, because during that time, you can actually assess to see whether the patient is ready, to pursue this line or not. If they're telling you no motivation at all, or I think I'm okay, then you know where you are with the patients. But if they tell you, I want to improve on my health, those are good conversation starters even to continue the conversation. And it's okay for them to be in the different stages. of change. Some are still in the pre-contemplation. Some are already contemplating on what to do. Some have even already made actions on what they need to do. And there are people who also present to us because they have done everything right, but now they have found themselves relapsing. All of these are important in the conversation we're going to have with our patients. The next one is the assess. Remember, we said open-ended questions when we're talking to our patients about this, because you do not want to put your own opinion on them, but giving them that open-ended opportunity helps them to express themselves. We should assess their BMI, measure the BMI, which most times has been done for us by our front staff team. We should also measure their weight circumference and determine what obesity stage they are in. During the assess is also the opportunity to identify drivers and complications of obesity. During those open-ended questions, they might talk about things that have contributed or provoked their weight gain. So sometimes just asking them, what is the heaviest weight you've been and what do you think contributed to that? They will be able to open up to you and say, maybe it was when during my last pregnancy, I just couldn't get rid of that weight. So at that time, you start to realize some of the things that have contributed to their weight gain. Again, I could also ask them about their current nutrition practices or their physical activity, and also further examine the coexisting medical conditions. Very important during the assessment is to also look at their medication list to see if they're taking any medications that increase weight gain. Next is to advise the patients on how to prevent, management to prevent or reduce other coexisting conditions. And then we agree on the target weight reduction. It's important to set realistic goals, one that is measurable within a time frame that the patient can achieve. We can say 5% weight reduction over the next six months is a good place to start. We can decide to pick on their nutrition. This is what they want to change, and reevaluate this within the next couple of weeks. Here are some of the resources for us as clinicians that we can use to get ourselves more familiarized and comfortable with having this conversation. Using the Obesity Management Learning Hub by ACP, the website is up there, and also going over the Obesity Medicine Association webinars. They have some of this on how to approach this topic. In summary, obesity is a complex condition associated with increased risk for other medical conditions. It is important for us as physicians to have conversations about this with our patients. Language and approach of the physician really matters in having this conversation. We can also make use of the 5 A's framework for obesity management, using the ask, assess, advise, agree, assist for our counseling. And again, interdisciplinary approach is the way to weight management. Thank you all for listening. Here are my references.
Yeah, go ahead, George.
Okay. Oh, okay. I'm George Lehman. Excited to be here. I work with Novo Nordisk as a medical liaison with the obesity team. Thank you for the great presentations. And I have a number of questions from some of the presentations when it comes to stigma and bias, because on a daily basis, that is something that I get to discuss with clinicians. So first, I have had people who say it is stigmatizing to ask a patient their permission to discuss their weight, because if they present with a high blood pressure, you go ahead to address it. So some people feel like there is stigma in itself asking someone if they're ready to discuss their weight. Why do we not ask, are you ready for us to discuss your blood pressure or blood glucose? So we'd like to get your take on that. Then I have had people ask, is the right word to use weight management or obesity management? That the diagnosis is not weight, the diagnosis is obesity. Why are we trying to shift away from the elephant we want to address? And then there are other names for obesity, adiposity, based chronic diseases. How do we manage all of these languages and take the stigma out? Thank you.
Oh, some good questions there.
Thank you for those excellent questions. That is true. We do not ask for our patients the permission to talk about their blood pressure. But I will say a lot of this when we talk about obesity or weight-related issues, it's also patient-dependent. Sometimes it depends on the rapport that you have developed with your patients. There are some patients that, after establishing with them, you feel more comfortable to address many of their issues and would not feel insulted, even if you talk about it. But there are some people that you would see in your practice that that they're very sensitive to things like that and would appreciate, you asking. So there's really no one size fits all for many of these things that we talk about. It's all dependent on your patient and how your patient responds to this. As regards diagnosis, it's true. We do not want to shy away from hitting the nail on the head, but it's also still patients' preferences. Like Dr. Shu mentioned in her presentation earlier, feel free to ask patients, what language would you feel comfortable with me using? Some patients feel better with you just saying weight in general, and they tend to respond well to that. Some people feel stigmatized by talking about, mentioning obesity. The entire care is patient-centered. It's not really about the comfort of the physicians alone in terms of our language, but what's going to help. Our goal is to help our patients to change and do things that, patients would prefer.
May I ask, do you think that some of the fundamental problems that patients, lay people, even providers have is that we still think that a lot of these conditions are the result of patient behavior at a superficial level, patient preferences, patient's lifestyle, rather than as providers, we're not digging a little deeper to see what is driving this behavior, what disease process is driving this behavior. Do you think that might influence the course of the conversation?
I think that it's a complex interplay of both, which is in some ways why I feel more job security because of artificial intelligence right now, It's a difficult job for us to manage with patients. And so because it's not one size fits all, I think there'll be a long time for human interaction yet. Kind of similarly, I 100% agree with everything Dr. Aladenjoy said. I think the language is very much so patient dependent. And I also think that, right now we're still learning so much about metabolic syndrome, about obesity or adiposity. However, we ultimately decide on referring to the subject. I also think that it's just a part of culture and context as we kind of move along. So, previously we referred to things like von Recklinghausen disease or Job syndrome, and we no longer call those diseases their current names. They're neurofibromatosis 1 or hyper IgE syndrome. So we are moving towards more specific language, and I think that this language will become even better, more descriptive, more specific as we learn more about these disease processes, while at the same time keeping it kind of contextualized and individualized for the patient. And so I think part of it potentially is cultural, but a large underdriver and undercurrent everything is also genetic. And so culture in part is genetic as well, right? You probably share a culture because you share some genes. And so I think learning the interplay between these two things, as well as learning the interplay of how interacting with people from different cultures and different backgrounds from your own is important, and an individualized approach and technique for providers, especially, when you're looking at the person in front of you as opposed to a disease process in general.
Mm-hmm. I don't see any questions in the chat room, and we have just a few. Yes, sir.
Putting aside a lot of nice terminology and just getting down to brass tacks, a couple, if one, do we know who's telling the truth and who's lying? I mean, I've had patient after patient who's 5 feet 4 inches tall and weighs 340 pounds tell me I only eat stew and boiled foods, don't eat fried food, don't eat dessert. I don't know, maybe so. I don't know why they're 340 pounds if that's the case. Number two, I do phys med rehab, and I go back to the 70s with putting cardiac patients on a treadmill and watching them exercise, questionable activity. But a lot of my patients say, well, On a good day, I go to the local park and take a lap around the park. That's not burning a whole lot of calories. And I know this is complex, but this leads into the whole issue of maybe the GLP-1 agonists are something we can latch onto. But A, they're awfully expensive, and B, there's a rebound. And if we're ever going to go to the TMA, which is going to go to the state legislature, which is then going to go to Congress to put the thumb on the drug companies to stop charging $1,200 or $1,300 a month for those, we need data. Do we have data? Who's lying? Who just is telling the truth but can't lose weight? What is our quotable standard for what the rebound rate is if you stop the GLP-1 agonists, say, after 6 months? How likely are you to put back some or all of that weight? Do we have numbers to give to legislators? Thank you.
Thank you. So, Matthew, there were a few questions there, right? One is, are the patients being truthful and honest when they give us a recall of what they've been eating? Number two is, do they understand what it means to exercise rather than just daily activities? And number three is, what happens when patients stop taking medications? Who wants to tackle those? Right. First of all, do you think the patients are being truthful when we ask them to recall what they've been eating?
I think something that frequently happens for me, and obviously, still a young clinician, learning how to get better every day. But I think something that frequently happens for me, even whenever, like, for example, I'm talking to my spouse or to, my niece and my nephew, it's like a breakdown in communication. I don't think ever that patients really try to intentionally lie to their clinician, but we're coming from very different walks of life. We're coming from a lot of training. They're coming from a place of, I just know myself. And, they may not know what the gold standard is. And so when I'm talking to my patients and trying to get a baseline, instead of asking them their specific thoughts about it, I find that it's easier to stick to facts. And so when I ask for them what are they eating and for a dietary recall, I ask for pictures if possible, as opposed to specifically what are you eating, do you think it's one portion size, all of these kind of things. Because, they may not know what an exact portion size is. And so, smartphones are a great invention. They've replaced a lot of computers and things that, used to take up an entire room. And so they can just take pictures of what they're eating every day. And then I know exactly how much that they're eating. Obviously, socioeconomic status comes into play, and, that's a part of it. But if possible, I think, smart watches these days are a lot cheaper now. And so instead of asking them to quantify how much activity are you doing, it is automatically done for us if they have the capacity and the machinery to do it. And so I think that is one component of the complex question. I'm sorry. The other components, I'll let you chime in.
Sounds good. I was also going to add to, we have to just allow some degree of trust for our patients. I imagine if I talk to someone as well and they're asking me if I'm really truthful, or I perceive that they don't believe me, it's going to affect how I take the management. So I think a lot of it would also be on us as physicians to just learn to trust. They may not always be truthful, but where they are, our goal is to help them. Excuse me. Our goal is to help them. In terms of the weight gain after stopping GLP, they're starting to have some research which shows that within about a year of stopping the Ozempic or semaglutide in general, people do regain the weight that they originally lost. So research, we still have to do more research to keep getting more data on this. And that's one of the reasons why we're having all of this program.
Thank you. And that phenomenon, the fact that patients have almost total weight recurrence after stopping, anti-obesity medication treatment, or in some cases even after surgery, they have a certain degree of weight recurrence, actually supports our theory that there is an underlying chronic disease element that we are not necessarily curing or eliminating, but rather treating symptomatically, if you will. And I think this is a major new approach that all providers must take, and patients too, that the disease of metabolic syndrome never really goes away. So that if you were to stop treatment, it is bound to come back. You might all recall a popular show called The Biggest Loser. Do you remember that? And for those of you who are not familiar with it, they bring in these groups of heavy individuals, and they would expose them to very high levels of strenuous exercise and activity on a daily basis. It was like a boot camp. And you know what? They all lost weight. But then the program ended. And guess what happened to all of these people? Everybody, each and every individual, even the one who won, regained all their weight, except for one. One of these competitors didn't regain his weight. And you know why? He got bariatric surgery. Anyway, it's actually published, and I should have brought up the reference, and it's in one of the medical journals. And there's an article that followed that as well. So thank you for the question, Dr. Kevorkian, because it's a complex issue. There are many, many different factors at play here. But essentially, we have to really embrace the notion that this is a chronic disease. And nobody claims to cure diabetes. Nobody claims to cure cancer. That is magical thinking. What we try and do is just reduce it, prevent it, maybe even symptomatically treat it, knowing in the back of our minds that it can come back at any moment.
Yeah. And then
Sorry, I just wanted to add one more thing. In terms of food or nutrition, it's important to also listen to our patients. Sometimes some may have financial issues. So just asking them generally what they like to eat might also be an open-ended question for them to tell you all the variable options. Not even putting it to them like, do you eat fast foods? Of course, they already know that you're trying to say that's not good enough. We can ask that, but in open-ended ways. So it's important to also put into context some of the socioeconomic disadvantages. Unfortunately, a lot of foods that we may consider unhealthy are sometimes much cheaper than eating fruits and vegetables. And if they really and really cannot afford it, our role is to provide other resources or places we can send them to get all those things affordable.
Right. And just to add to a question about data regarding semaglutide, which I'll touch on a little bit later, but there is a study that looked at people off semaglutide after a year, and about on average, people regain about 2/3 of their weight after coming off semaglutide. And I think that just further shows to what panels were saying, that obesity is really a chronic condition. And after taking away the appetite suppressive benefit of semaglutide, it's really hard to maintain the weight loss.
Thank you. George. You're like the clever
Sorry,
student at the back
I have
there.
a lot of
Yes.
questions because I cover half of Texas and I get all the questions. I'm bringing them today here. So we talked about obesity being a chronic disease, which I agree. But I also mentioned, I recall, I think Dr. Zhu mentioned, maybe it's Dr. Poluri, mentioned that they win off patients, then they watch after, right? So I think I remember made mention of that at some point they start patients with medications, then they stop and watch. Does that make the case for a chronic disease? Do we manage other chronic diseases like that? Then the other thing, and I promise I'll sit down after this, I've had pushback about the 5 A's that you mentioned, Dr. Bumi, that if you're taking something from smoking cessation, which was more of a behavioral stuff to use in obesity, are you still bringing the conversation to be around behavioral choices when it comes to obesity instead of metabolic? So smoking cessation, we're trying to manage behaviors. You're taking a tool for smoking cessation to use for a metabolic disorder? How do we justify that? And I promise I'll sit down.
Excellent question. When it comes to management, talking about the 5 A's, lifestyle is still a component of management for obesity. We cannot separate that. We should still have conversations about that. But in addition to that, making patients aware that even if you're doing all of the lifestyle things, there is still pharmacologic and surgical options for weight management. But otherwise, I think we should still bring up lifestyle with all of our patients.
Absolutely.
Also, kind of talking about the weaning off of medications and things like that, we do actually do that for a lot of other conditions. You know, we know for a fact that with high blood pressure and diabetes that we treat very commonly. Initially, we may need, because they didn't recognize that, you know, they had this disease process, we may need a lot of pharmacology and medications to treat these conditions. And then once we get that A1C under control, or once we get the blood pressure under control, and we have also gone ahead and taken the additional steps in making lifestyle modifications, sometimes they can come off of a lot of the medicine. Sometimes they can come off of all of the medicine because we've identified the triggers in their prior behaviors that were kind of manifesting or allowing the kind of genetic component of their disease process to kind of come to the surface. And so I definitely think that, as Dr. Olatunjoye said, you know, lifestyle is a critical component. Genetics, you know, leads to predisposition, but it's not the end-all be-all. And lifestyle also is not the end-all be-all. It can help, and certainly it can, after some intervention, be the treatment, but it doesn't necessarily have to be all of this or all of that.
Thank you. Yes.
I'm sorry, I know we're running a little short on time, but I think there are some chat questions that popped up from people that are in the virtual audience. So one of the questions, do you have a post-bariatric surgery weight management program? That most patients gain weight after 2 years and has no place to go. That's one of them.
I didn't catch the question.
Post-surgical weight management when they regain the weight.
Is there a program?
So the question is about post-surgical weight recurrence?
Whether we have a program to manage that.
Absolutely. So the answer is yes, it happens to some degree. We know that about almost all our patients after they reach their nadir, their lowest point of their weight loss, they can gain about 5% back again. It's like a little bit of an inflection there. There are some patients, for a variety of reasons, who regain more than that. All the patients the vast majority of patients that I interview tell me that their appetite remains diminished compared to baseline. But some patients whose weight recurs might be due to some mechanical underlying cause, such as an enlargement of their stomach pouch or some abnormal connection between the pouch and the stomach in cases of gastric bypass, and we'll talk about the operations later on today. Other patients just don't follow up. And, you know, we've mentioned several times today that the metabolic syndrome is a chronic disease. And our patients require chronic support. And in our program, we never discharge patients. But we do have patients who stop following up. And you'll find that this is a common theme among patients whose weight recurs, is that they stop receiving support and counseling from the program where they had their operation. Plus, there are other factors that may play a role. There might be stressful circumstances that develop in a patient's life, or there may be medications that they start on that promote hunger or weight accumulation. And so we have to investigate all of these. So when patients do come back with weight recurrence, we once again apply the multidisciplinary approach to them and cover all these areas to see what might be driving the weight to recur.
And another question on the chat was, so I have had a difficult time counseling patients and goals for weight loss. I have patients who want to get down to their college weight, patients who want functional improvements, patients that fixate on ideal body weight. How do you approach this with patients like this?
That's a great question, which I was going to ask you actually, both of you, is when you counsel the patients about weight loss, what goals do you give? Do you give them small incremental goals, or do you give them like, let's get you back to what you were in high school?
I think having both types of goals is important. I approach weight loss, if that is the goal of my patient, to get them to a healthier weight, similarly to how I approach financial planning. It's important to have short-term goals, right? And then it's important to have like a long-term goal, because we should celebrate your milestones along the way. But in order to build confidence, you actually have to have SMART goals. So short, measurable, achievable, timely goals that are reasonable. And so having both is nice, because having the big goal is something that they can look forward to, like a birthday or a celebration or something like that. But having the small goals is what actually gets you to the big goal. And so I think it's a both kind of thing.
I agree with you. I think you summarized it all.
I agree as well. Do we have any other chat questions?
I think last question in the chat is if we are really to treat this as a relevant medical condition should we be this tentative about addressing weight issues? Shouldn't management of weight be incorporated into management of coexisting medical conditions or its prevention?
Well, that's an easy question, yeah. What do you think, Dr. Bunyan?
If we're going to treat it like other medical conditions, yes, it should be incorporated. But how many people really would count that as one of their medical conditions that they really want to discuss? It's still an emerging field, and I think one day we'll get there. But it starts with us as physicians also having a high index, or bringing that to our own awareness to discuss it. Over time, patients will catch this as well and be willing to discuss. Albeit there are more patients now willing to discuss weight. I think after the launch of Ozempic and a lot of celebrities used that and lost weight, we've actually had more inflow of patients coming over to want to discuss their weight. So I think it's a moving target, and we will get there one day.
I also think that while that should be our ultimate goal, like Dr. Matar referred to, not everybody recognizes their weight as being a problem, with that very kind of enlightening statistic. And kind of also additionally, not every health problem is as stigmatized as weight is. Like in popular culture, weight is a big stigma. You see that talked about, like, in order to get into the acting field or anything like that, you have to look a certain way, you have to be a certain way. Nobody does that with high blood pressure. It's kind of like a much less visible kind of chronic illness. And so I think because of that, even though we would ideally like for it to be that way, I think it's important to recognize that it is impossible for it to currently be that way.
Yeah, I mean, the easy answer, the quick answer to your question about incorporating weight management and chronic diseases, yes. The problem is that healthcare providers, to be totally frank, are not equipped, as you mentioned in your talks today, about how to open the subject and how to discuss it. Plus, they might not have the time. If you've got 10, 15 minutes to see the patient, you're already talking about their blood pressure, their diabetes, their sleep apnea, and now you want to talk about their weight. So what needs to happen really is an overhaul of the whole medical school curriculum. Go back to medical school, maybe even go back to high school, and introduce weight and weight management as a central component in biology and then in medical school. And that's happening actually. They are refurbishing, for a better word, medical school curricula to include more study periods in weight management.